Okay, welcome back, everybody, to the show. I think our phone line, Dr. Jones, you still with us?
I'm here.
Okay, are we going to get any, so Roger, people can call in?
Well, we're going to have to merge the call.
Okay, so how would we know if they were calling? You'd just see a...
Yeah, I just see it on the phone.
Mm-hmm.
Give me 1 second.
Is it?
Nobody's called so
Oh, nobody's called so far? Oh, come on. We don't have any calls? Everybody left?
Oh, they're listening.
Well, if we don't have any calls, you know, how about we just go around the table in case unless somebody does call in, and we'll you'll let me know, and we'll just start with the left side, or actually let's start with the speaker first, Dr. Jones. Any final thoughts regarding what we've been discussing today? And we're just going to kind of go around the table here and move forward.
Well, like I said earlier, I think this is something you want to have in your armamentarium for certain cases. And it does benefit the patient,
you have a call?
and it's something that you can
Hey.
easily adapt.
Hey, Doc.
Yeah.
I'm sorry to interrupt you. We did get a call for a question, so we're going to interrupt
Okay.
you. Okay, and we're going to merge the calls. Hold on. So,
I'm back again.
okay, hello. You have a question
Hi
for
there.
us?
I sure do. Stephanie, can you talk a little bit about
Do you mind?
how the potassium is administered?
Yeah, I'm so sorry. Do you mind telling us who you are and where you're from?
Sure. This is Patrick calling again from New Orleans.
Oh, hey,
I'm sorry,
Patrick.
from New Orleans, from Houston.
Okay, you actually work with us, but I didn't recognize your voice. Okay, what's your question?
I wanted to ask Stephanie about how the potassium is administered. You mentioned you don't give it all at once, and I wanted to hear a little bit more about that.
Sure. So we initially start out, I have 180 milliequivalents drawn up of potassium in a syringe, and I just give it slowly over a few minutes, and you'll just see the heart gradually start to stop. I say more times than not, we do add another, I'd say 40 to 80 over time, but only to if we need it. If Dr. Mettauer is complaining that the heart's still beating and he needs it a little more still, I'll just keep giving a little bit at a time until we get to where we need to be. Would you say that's about right, Clint?
Yeah,
over
we
a few minutes?
We do the same. Like I said, we start out with 180 milliequivalents as well. More likely than not, we do have to add a little bit throughout the procedure.
Mm-hmm.
Every once in a while, you'll get a little beat here or there, and you'll hear either Dr. Jones or Dr. DeWitt, who Dr. Mettauer was talking about earlier, who he trained with. Of course, they'll let you know as soon as you get a beat.
The heart's beating. Oh my God.
It's not about. It's just it
It's just
changes the
they're trying
dynamic.
to
I mean, it
work.
really
Right.
changes it quite a bit.
That's what it is. I think the biggest key is a gradual delivery. And like I said, what helped us out with the cases that we've done quite a few here lately, is when we kind of put our heads together and kind of figured out, cooling this patient a little bit is going to, help us out. Anesthesia, starting some Esmolol, putting an Esmolol drip on. Like I said, it significantly reduced the amount of potassium that we have to give during these cases. And I mean, I'm assuming you guys probably
We
do
do
the
that.
same over there. Considering
So we usually
Joe's done it.
start the Esmolol drip when we go on bypass,
Correct.
and then when we start taking the potassium off, we shut it off.
We do the exact same.
Okay.
And I don't want to, I think that, I don't want a perfusionist out there to be freaked out about, cases like this. I mean, honestly, yes, it is helpful to see one, and it's, kind of freaks you out the first time you hear about what you're doing. But, for us, and I know, of course I had Joe there to help me learn how to do it, but, now it's like any other case. I mean, it really is. I mean, the setup is not extremely difficult. I mean, you take your cardioplegia setup out and, replace it with, the setup to do the CVVH. And I mean, there's not much to it. So, I mean, I don't want freak everybody out and think that this is something crazy
It's really
that
pretty
nobody
simple.
can do. It is.
Yeah, we had put the
know-
diagram up, that diagram that your brother drew that for us, right?
He did.
And he's a CAD designer, a CAD drawer, or whatever. But let me just ask everybody here, Dr. Jones, Dr. Mettauer, Stephanie, Minh, Clint, of course myself as well, if anybody out there that's watching this wants to try that, whether you want to talk surgeon to surgeon or perfusionist to perfusionist or whatever the case may be, you're welcome to reach out to any of us. We're happy to discuss the case with you and help you get through the first one if that's what you'd like to do.
No
You
doubt.
know, one thing I switched to, I did have the second hemoconcentrator going through a roller head, and that just helped ensure that we didn't get any backflow or air into the system. But we had a case where we needed an extra vent. So I had a pump for our dialysate, and then I had a pump for the hemoconcentrator, and I had to pull my hemoconcentrator out to vent. And what I found is that once I added a one-way valve into the second hemoconcentrator, so I wasn't worried about backflow in that anymore, it really simplified it for me because I'm not running that as an extra pump and having to watch it. It just went continuous. And,
Now, see, I don't like that. I don't
Okay.
like it because when you have that line going into the top of the reservoir, and we use vacuum assist venous return, that's a negative pressure. And so I like to use the roller pump because I can generate a much higher pressure in the blood phase of the fibers, and it helps to push the ultrafiltrate out a lot faster, and I can ultrafiltrate a lot more volume in a shorter period of time. So that's why I like to use the roller pump.
With the positive
Not
pressure,
necessarily
right.
for the flow, I do it for the pressure, for that positive,
positive
pressure,
pressure.
in the inside of the little pipettes, the little fibers.
I haven't seen that it slows down any, but maybe,
Yeah, I mean, maybe I just need to
because
try it.
if I still ran my dialysate at the same rate, so
Did?
I don't.
But you're
think-
hooked up to a Neptune though,
yes.
right? And
yes.
that's massive negative
Yes.
pressure. So, do you recommend you use a Neptune, or you use suction, or do you let it just flow through just the pressure gradient
Oh, I think
into
it's
atmospheric pressure? Or do you hook it up to a suction?
I hook it up to
You
suction
need
too.
suction
Yeah.
for
Yeah.
this.
Yeah, I agree with that.
The gravity drainage is just going to take way too long, and it's going to extend the procedure out, and it's going to get these guys on our back.
They
in
get
bad shape.
anxious. They get anxious.
They say they're patient, but they're ready to come off when
not
that valve's in.
I know. Well, but that's directly contradictory to what you just said a
Right.
minute ago. There's no worry.
There's no
if it just
rush.
takes a little longer,
No, you're-
that's
but I'm
okay.
telling
you're
you.
on pump. That's fine.
I'm patient when it comes to what I'm doing.
Yeah,
Right,
exactly.
exactly.
Exactly. When you're
And then when
ready
that
to
valve
come
is
off,
done, the
we
heart's
need to be
closed,
ready to come
you're
off.
ready to
And
come off.
chances like that too, Dr. DeWitt. Another call? Okay,
Thanks,
Patrick, thank
Patrick.
you. Another call? Oh, no. Hello?
Hello?
Hey, who's this? This is Joe.
Oh, this is Gopi Kalura. I'm a perfusionist.
Hey, Gopi, how are you? Nice to talk to you. What you
Yeah.
got? What you got, Gop?
I just got a question about they didn't touch the basis of the perfusionist point. Can they use?
I'm sorry, Gopi. Can you say that again? I didn't understand your question.
I said, what cannulation technique do they use?
Oh,
Oh,
cannulation.
yeah.
Oh yeah, film. I mean, you got to be. I mean, that's. I don't know.
Well, you
if
could
we
do.
wanna do any other way
If you
than
got
that,
horrible
but-
peripheral vascular disease, you could do femoral venous, and an axillary.
Yeah.
I mean,
yeah.
I haven't done that, but having
I just
peripheral.
wanted to know what kind of cannulas did you use?
Oh, you
That
can use
is
the
most
Edwards. You
crucial
can use
part.
Gopi. You could use the Edwards,
Medtronic.
or the Medtronic, or the Soren, I think, or Libanova, whatever they're called now, has their own version of Aztec cannulas. I think is what they're selling. The and I mean any standard femoral cannula like you would use if you had a redo and you just wanted to cannulate and go on pump, or you were doing VA ECMO.
Right, a
Exactly.
percutaneous cannula set, but through an open technique.
Right.
I mean,
Yeah.
so
Right, absolutely.
so you're not sewing it into the artery or using umbilical tapes or silastic loops or whatever. Basically, I mean, sometimes you have to, but basically, you want to get enough of the cannula in there. When I was at Texas Heart, we used the old cheap beveled aortic cannulas, and barely there's like a centimeter tip in there. And but the Edwards percutaneous kits, but just do
optics, yeah.
but just do an open technique that way, because the surgeon's gonna have to fix it afterwards. You know. And but the options would be axillary film or fem-fem.
Right.
Hey, Dr. Jones, you still with us?
Yes.
Hey, can you talk about placement of the venous cannula? Because if you've got crummy drainage, the procedure is horrible. You know, so you know, placement and drainage is critical. So what is your placement? Where do you choose? Where do you attempt to place the tip of that VFem cannula to get the best drainage?
Yeah, I want that area in the superior indicator. Because then I know that I have the vascular opening in the body right atrium. Therefore, I think I get better venous drainage with that position.
So where do you put it again? I didn't hear you.
Well, I like the tips of being in the superior indicator.
Okay, so you put the tip. So you go all the way up through the atrium into the superior vena cava with it.
With the tip, yes.
And you can actually feel that through. You can feel
Right,
that right through
you-
your thoracotomy.
Generally, I mean, unless you got
Yeah.
unless you're 6'5" and 300 pounds, and then anesthesia helps, because sometimes that tip does go into the atrium, and then you have drainage problems.
At least about an inch inside the SVC.
Correct. Yeah.
Did you take it?
The atrial lifter will
This is somebody
sometimes
else.
change that, so you may have to modify that and place some in a little bit further when you lift, because it may pull it out of the SVC. But it's pretty easy to manipulate from the groin and the chest at the same time.
Now we had a case one time. I think it was you I was doing the case with, and the drainage was horrible. I don't know if you remember that or not. And I think they were just yanking up on that lifter, and it was, you know,
Oh,
just
I
a
do
real
remember that, yeah.
difficult anatomy, and they really had to yank up on it. And that cannula wasn't in the superior vena
It
cava.
flips out and goes into the atrium.
Yeah, and we stuck that cannula in the right IJ. You remember that?
Right. Oh, yeah. So
we
you
put an opti in the right IJ
Yeah.
and wired them together, and it was beautiful.
Right, that's another option, is you can dual cannulate that way, kind of like you know, traditional mitral surgery, except you're doing it through the IJ and the
Yeah.
and the femoral veins.
And you just use a little small arterial cannula, and with the vacuum assist, it just worked. It really worked well. I mean, it got us out of
It
the
did.
heart decompress, everything. It just calmed everything right back down again. Yeah, you have bad drainage and the heart's stuffed, and you can't.
Well, and that's
see.
the other benefit
That's
of
just
not having a
painful.
retrograde cardioplegic catheter in. You got that access, the neck's open, ready to be used. In case that happens, you can really stick a right IJ catheter in real quick.
Did we have another caller?
No.
No. Same. Did we have anybody else online?
Yep.
Okay. Well.
I guess I have one last thing to add.
Yes.
And then Clint can. We have really an astounding heart team at St. Luke's, I would say. And one thing that helped me a lot was having good circulators to,
Oh, yeah.
I mean, we get a ton of calls from the lab, from the pharmacy. You want how much potassium? You know,
And I
you
fight-
know
I
your
fight that
K is
battle as
this.
well.
That's a battle. That's a
Yes,
battle.
and
That's a battle.
having good people around you helping me to get the solutions I need, the potassium I need, getting things to the lab quickly. I think that really helped alleviate a lot of the problems that if you are trying to do this as a perfusionist by yourself and the surgeon's like, okay, you take care of it, and no one's helping you in the room, then I do think like you have to be really prepared and planned out and talk to each department and be ready.
Well, let me, you know, you brought up that's a very good point, and I'll add something to this. What we use to monitor labs, okay? We really need the
You're talking
Siemens
to-
Rapid
yeah.
Point
I get it.
in at St. Luke's. No, I'm being serious about this. We use the iStat. The iStat will only read a potassium to 8. All it says is greater than 8.
Right.
We don't know if it's 8.1 or it's 15. So it's hard for us to kind of assess. And of course, you know, I don't want to get into the minutia of, you know, the simplicity of just, I mean, what do you think of that Siemens machine? What's your view?
Nobody's paying me to say anything, by the way. So I love it. I mean, it made ours, you know, the process, I mean, a lot simpler. I mean, it gives you the result right there in front of you. You're not having to wait. I mean, you're not guessing at, like you said, where you're at. I mean, you have it basically right there. I mean, if you're at 13, it's going to tell you you're at 13. If you're at 12, it's going to tell you you're at 12.
And you have confidence in the values.
100%.
Okay, and
So
we
have
use
you been in the range of around 11 to 13 most cases, 12 to
Now,
13?
yes. When we
Okay.
first started, I mean, we had got up to,
18.
18, 17, 18, and
Again, it doesn't. My point is that it's crazy, but it's no different than 12.
it's not.
It's gonna
I
come
mean,
off.
think about
takes
it.
This is
longer.
true.
It
This
just
is
takes
true.
longer.
This
That's
is-
all.
Yeah, but it just
as
takes
long as
longer
you
to
have
get
the
it out.
solution to
It
get
sounds
it
like
off.
pure insanity, but it's
Right.
not. It's
Mm-hmm.
just
Yeah.
it's
As long as
really
you got the solution and good perfusionist to
Yeah,
take
just
it
don't
off.
run out of
not
the
a lot.
solution.
A lot of
and
new
you'll be in
stuff
trouble.
out there for heart surgery, but I think this is pretty innovative.
Well, I think unless anybody has anything else, we've had a great session. We're going to go ahead and, we have a studio audience. Nate, do you have any questions? I didn't even address the studio. And Nate's shaking his head no. Absolutely not. He's retreating now out of the door. He's running
He
down
hasn't
the
said
hall.
a word.
Has not said a word. And that is highly unusual
Nate,
because
would-
Nate
So unusual.
It
is
is
Would you feel
the...
comfortable doing the next one after this
Yes.
talk?
Nate.
Yes.
Yeah.
You're
Wow.
doing it. Oh, he's doing the next one. He's doing it. You're going to have to, Nate. I'm sorry. It's just part of the program. But we've had a great time, and I can't thank all of you enough for participating in our first webinar of our webinar series. Don't forget our website, perfweb.us. Don't forget the conference, theneworleansconference.com. So on behalf of myself and this illustrious panel that I feel so privileged, and Dr. Jones on the phone from Louisiana, beautiful state. Crawfish season's here, but I'm worried because it got really cold.
Yeah, they're gonna be small.
They're gonna be small. The Saints are out of the playoffs and the Super Bowl chances, but that's okay. But I hope to see you again at our next one. I think it's scheduled for February 7th, but you can go online and see that. And we're going to try to keep these topics fresh and new and different. So if you have any ideas, look, email me. You want to be part of this and do it remotely through Skype or through the telephone like Dr. Jones did, let us know. We're happy. We're looking for people that want to be involved and part of the education process and part of the overall goal, which is to help improve the outcomes for our patients and to share educational information. Information was meant to be shared, not just held to yourself to make yourself look good. It's supposed to be about a greater calling. So let's all keep that in mind. And once again, thank you all very much.
Hey, Joe.
Yes, sir.
Okay. I was gonna say one thing.
Go ahead.
Don't forget, this is New Orleans' 300th birthday.
That's right.
So the New Orleans conference will be here, and things are going to be happening in New Orleans. So it's a good time for people to sign up right now to attend.
That's right.
Yeah, they're not gonna be in hotel rooms.
So no, we've got them booked.
Well, that's what I'm saying.
We have a
Better
block.
You better get the
If
block,
you wanna come,
right?
you better book.
So, Dr. Jones, do we need to add a day to the block for recovery?
Probably.
Probably.
All right. Thanks, Doc. You take care of yourself. Great talking to you, and thank you so much for participating.
Thank you, Joe.
Thank you all very much again out in Web World. Have a good day. Enjoy your Saturday.
How about it?